Well, hello and welcome to Sunday morning coffee with Dr. Childress here. Today I'm going to be discussing the diagnostic protocol for the pathology in the family courts. Um, and the one of the primary issues around the family courts is everybody fights about everything over here. And that makes it very dangerous for clinical psychologists to work here because there's one party in the litigation and the pathology, narcissistic borderline, seeks to retaliate against the clinical psychologists who are trying to alter what the pathology wants to do. They're trying to treat it, they're trying to fix it, and that narcissistic borderline dark personality parent doesn't want that. And there's flying monkeys around that as well. And so it's a very dangerous place for a clinical psychologist to be, which is why you won't find any here. I'm the only clinical psychologist over here. Um, but because you guys, everybody fights about things because of the court, and there's an effort to undermine the credibility of expert witnesses, from each side. There's a lot of fighting around. They'll be fighting around Dr. Childress and what I'm saying. Now, that wouldn't occur in ADHD or autism or eating disorders or anywhere else. The mental health people aren't attacked. And so I never faced any licensing board issues until I came to work in the family courts. And now I'm getting hit because it's dangerous because of the litigation thing. There's people who want to damage me in between my testimonies because they know they want to damage me for future kinds of things. So this is a very unique place to work over here in the family courts, and we'll talk about that later. But one of the things as a clinical psychologist, when I came over here and started to move into private practice and took a family in the family courts to see what's up, and then recognized as I'm falling down the rabbit hole of the family courts and the pathology over here, it came to recognize that this is active child abuse, psychological abuse of the child, active spousal abuse of the targeted parent using the child as a weapon, and nobody's doing anything to stop it. And the forensic psychologists are just like absolutely lazy, and they're nonchalant, and 6 to 9 month evaluation, then it takes another you know 6 months, 9 months, a year in the courts before the evaluation finally. That's a year, and this is child abuse and spousal abuse. So the forensic psychologists have failed to respond with the urgency demanded by the nature of the pathology. And because of that, it's lulled everybody into sleep because the psychologists have gone asleep. They're ignorant like a rock. Um, and so I stayed over here as a clinical psychologist. I am competent in all the domains, a lot of domains, attachment pathology, delusional thought disorders, complex trauma and child abuse, factitious disorder, family systems, and now in this court involved pathology. So I know what I'm talking about. I know what I'm doing. And I'm not making up new theories. I'm applying knowledge to the pathology. But everybody's going to fight about that for a while. Oh, Dr. Childress has a new theory, and I know I don't. And there'll be lies, and they'll try to slander me and attack me any way possible. Currently, the Gardner PAS experts and the forensic psychologists um, are basically just ignoring my work and ignoring the issues that I'm raising relative to each one of them. They just like put their fingers in there, la la la. I'm not going to pay attention to anything. What all I'm advocating for is that we apply the established knowledge of professional psychology, complex trauma, attachment, family systems, delusional thought disorders, DSM-5. That we apply the established knowledge to the pathology in the family courts. And people are fighting about that. No, we don't want to apply the knowledge. No, no, no. Yeah, that's going to happen. We are going to apply the knowledge, and we are going to fix the pathology. And the folks who are fighting against that are simply going to be exposed. And that means the forensic psychologists, that means the Gardner PAS people are going to be exposed for their obstructionism and their exploitation of families. But I've solved the pathology. I applied the knowledge from clinical psychology, and I've given you a diagnostic assessment protocol. Now, if you don't believe me, take it into a pilot program for the family courts and develop the diagnostic assessment protocol and the treatment protocol for it. That's fine. You're going to wind up in the same place I am, because I'm telling you, this is going to do it. And once you are motivated, once the professionals are motivated to actually solve the pathology in the family courts, they're going to go down this route because I know what I'm doing. I'm a clinical psychologist and I know how to diagnose pathology. So today I'm going to talk about the diagnostic assessment protocol. And I think all parents should be asking their mental health people for this information, because diagnosis is a pattern match of symptoms to the diagnostic criteria. It's not an opinion. If you have the symptoms for schizophrenia, hallucinations, conceptual disorganization, and delusions, that's your diagnosis, whether you like it or not. You pattern match your symptoms, pattern match to schizophrenia. So you have the diagnosis of schizophrenia. So the first step in diagnosis is to identify the symptoms of concern. So that's what I've done. I've identified the symptoms of concern that if you collect these symptoms and you apply the pattern match to diagnoses, you will reach the accurate diagnosis 100% of the time. And so the information I talk about, the diagnostic checklist and the parenting practices rating scale there, that's the diagnostic protocol. Just two symptom documentation instruments. You give me this information and I will tell you 100% time with accuracy what the diagnosis is, based on this symptom information. But it's all up on my website. So if you go to drchildressconsulting.com. I have 3 areas. It's over there. I have an attorney resource page with a lot of handouts. I have a mental health consultation page. That's where these forms are, that describes the pathology. And then I have a parent resource page that provides various things that might be useful for parents in your advocacy, for in your family, or just generally that sort of thing. So that's just a useful place for you to go and look around. But the 2 forms are the diagnostic checklist for pathogenic parenting and the parenting practices rating scale for the targeted parent. We want to show that the targeted parent is either abusive range or normal range. We need that question answered. So as part of the diagnostic process, are they a normal range parent or are they an abusive parent? Because that's half the differential diagnosis. And so the first piece of the diagnostic protocol is about the child's symptoms. We want to identify the pattern within the child's symptoms. And so there's 3 specific symptoms that we need to look for because they are impossible symptoms. They never show up. The prevalence of the 3 diagnostic indicators out there in the general population is 0. They never show up because they are impossible symptoms. But they will show up with this pathology because it's a factitious disorder. It's a false pathology, so it's producing a false symptom display. So any one of these 3 will accurately diagnose the pathology because it's an impossible symptom. However, I've given you 3 impossible symptoms that show up because if you've got all 3, there's only one explanation for that. And now I can make the diagnosis off any one of these 3 diagnostic indicators. And 3, obviously, it's a persecutory delusion. That's what we're worried about. But the attachment system is also a factitious attachment pathology. And children don't develop personality disorders or phobic fears towards a parent. So any one of these 3 symptoms will diagnose the pathology. But because your mental health people are so ignorant around you, I've given them 3 to help support them, plus 12 associated clinical signs. So 12 additional symptoms that are not always present. And that's why they're not diagnostic indicators, but they're often present. And we'll talk about those in a second. So there's a if you take the diagnostic checklist and you're seeing the three diagnostic indicators are present, there's only one explanation for that. That's a shared persecutory delusion. You got a delusion in diagnostic indicator three, and the second one, the narcissistic symptoms or the phobic anxiety, that's the fingerprints of psychological control by the parent. Either they're creating a high anxiety, phobic anxiety symptom display, or they're creating a narcissistic personality symptom display. And they're leaving their fingerprints of control onto the child's symptoms. And then the attachment suppression towards a normal range parent. Um, that's a false attachment pathology. Normal range parents, children do not reject a normal range parent. That never happens. So if all three of those are present, there's only one explanation. But then if you also look and you have six, nine of the associated clinical signs, something like that, then that's just further support, because those are symptoms that don't show up in any other pathology. So let's take a look at the associated clinical signs for a second, though, because these are interesting. And what I did with these, all the other stuff I talk about is the application of established knowledge, but the 12 associated clinical signs are from Dr. Childress. So these are symptom features, and each one has a reason why they would be present. And I can explain that in some future seminars and all sorts of things. And there's a reason for each one of these being present. But they're very characteristic of this pathology. They won't always be present. That's why they're not diagnosed. But if you see a lot of them, or screening, if you're talking with a family and all of a sudden you get a few of these associate clinical signs here, you're on the right track. These only show up with the pathology. And so the first one, ACS1, is use of the word forced. Okay, I can't force the child to get in the car. The child shouldn't be forced to have a relationship with the other parent. Child should be allowed to decide. And that's number two, is the child should be allowed to decide, empowering the child to reject the parent. So that's, and those two, one and two, often go together. I can't force a child to get in the car. We need to listen to the child's voice, kind of thing. And you'll hear this from the mental health people too. And so this is a good way of identifying the mental health people, especially number 11. We'll get to that. Then the number three is exclusion demand. That's where the child says they don't want the targeted parent at their soccer game, at their sporting event, their award ceremony, the graduation. They want to exclude the targeted parent from the event, and they say, oh, because it stresses me out or something like that. And so that is, in my view, almost 100% diagnostic. It is 100% diagnostic in my view. When that symptom three is present, exclusion demand from graduation, or that we're looking at this pathology, shared delusional disorder, factitious attachment pathology. Parental replacement, number four, is calling the targeted parent by the parent's first name. Instead of calling him mom or dad, they start to call him Bob or Mary. Or calling the step parent of the narcissistic parent, narcissistic borderline dark parent, calling that new step parent mom or dad. They're replacing their parent. If that's present, the pathology is present. So 3 and 4, I view, if those are present, there's only one explanation. And we're going to see everything else. You collect all the other symptoms, but if 3 or 4 are there, we're looking at the pathology, because this is the only place that those two show up. They don't show up anywhere else. The unforgivable event, that's pretty characteristic. There's been some past event, and the child, uses that past event as for justification for all current and future rejection. Liar and fake, using the words liar and fake, especially around when the targeted parent says, I love you. And they say, oh, you're just, that's fake. So fake, liar. They acted differently when they're alone than when they're with other people. They're such a fake, all those kinds of things. And so, with the use of the word forced and number six, liar and fake, I'm predicting use of specific words. So the scientific method is to develop a explanatory model and then use that model to make a prediction. These are predictions. Okay. And I'm predicting that's going to be specific words. Holy cow. No other diagnostic model produces specific words, but you don't get specific words for ADHD or eating disorder. But this is a pattern pathology, it's trauma pathology. And there's reasons for these specific words. So if we find these specific words in use, that validates the model that produced this prediction. And that's part of the reason I gave you the 12 associate clinical signs. Might as well make the prediction. Um, the reasons for rejection, there's a set of those: anger management, you know, is probably the most typical one. The interestingly one is not feeding the child appropriately. I added that later because I'm not quite sure where that comes from, but it's fairly frequently there's an allegation that somehow the targeted parent isn't feeding the child appropriately, and we have to send food over to the child or stuff. So that's an interesting one. Number eight is the unwarranted use of the word abuse. Whenever we use the word abuse is used, we need a proper risk assessment. We need to make sure that everybody's safe. But if there's no abuse and one parent is claiming the other is abusive, but there's no abuse, that's characteristic of a borderline kind of situation, and that's characteristic of the Machiavellian manipulation. And so that's why we need to come in on a differential diagnosis on this. So the word abuse, boom, let's get a proper risk assessment to the appropriate differential diagnosis for each parent. Excessive texting or use of the phone, high anxiety. This is my sense is this happens a lot with the borderline personality. As a child's over with the targeted parent, they're intruding into that other parent's time. Role reversal, number 10, is the saying, it's not me, it's the child who doesn't want to, answer the phone. It's not me, it's the child who doesn't want to go on, be with the other parents. It's not me, it's the child who wants to go to this specific school. It's not me, it's the child who wants to take dance lessons instead of baseball. So they hide behind the child. It's not me, it's the child who, role reversal situation. Number 11, you're going to find a lot. I mean, that's the basic theme of the whole thing, that the targeted parent deserves to be rejected. And that's the spousal abuse theme. Yeah, of course I hit her. She deserved it. My dinner was cold. She deserved it. Okay, that's the absence of empathy is a capacity for cruelty. And so that's what we're looking for relative to the child and the other parent, that it's okay to be cruel to people if they deserve it. That's the narcissistic value. The actual value system, healthy value, is we're not nice to other people because of who they are. We're nice because of who we are. And so that's the authentic value system. We're nice because of who we are. The narcissistic value is it's okay to be cruel if they deserve it. And then that's the spousal abuse theme. And that's what you'll see in this. That if you challenge that the targeted parent didn't really, well, they deserve to be rejected. And you'll hear that in the mental health flying monkeys around you, that there's something they imagine called justified estrangement. Is it justified? No, it's never justified. Rejection of a parent is severely pathological. That's a severe attachment pathology that's destroying the child. There's nothing justified. There's nothing normal in that. And so what you're saying, if by justified estrangement, is that parent's abusing the child. Well, if that's the case, let's diagnose child abuse and put it on a treatment plan. But there's not justified, it's child abuse. And so we need to start using actual words here and actual terminology and stop making up estrangement and alienation and justified, whether it's we need a proper assessment of child abuse if you got a child rejecting a parent. And then the final one, the disregard of court orders. Narcissistic borderlines just can't get themselves within the structure of what other people want them to do and the court wants them to do. Now, interestingly, Greenham, Childress, and Pruder, Melanie Greenham, got a memorandum of understanding to get access to Dorsey Pruder's custody resolution method data, archival data on these big old families. I'll do another talk maybe about that down the road. So Dorsey Pruder is doing a research method. Essentially, she's brought over research methodology into the family courts because the mental health people are refusing to provide these symptom information. I can't believe that. Imagine going into your doctor, taking your kid into the doctor and saying, "Doctor, what are my kid's symptoms?" And the doctor says, "I'm not going to tell you what your child's symptoms are." You want a second opinion from Dr. Childress. Okay. You want a second opinion on their diagnosis. Dr. Childress wants these two instruments. He wants these symptoms uh, documented, identified. Are these symptoms present? I need these symptoms answered to be able to provide an appropriate second opinion on what the pathology is. But the doctors are refusing to give the patients the symptom information to allow for a second opinion. They're just saying no, because it will expose that they are ignorant and incompetent, and it's malpractice. So if they, because they don't know how to assess for delusions, they don't know how to assess for any of this, and they haven't been assessing for any of it. And so if they start to, they're going to be exposed for their malpractice. So they simply say, no, I'm not going to. And then they fight about me and, whatever it is. But there's no reason that they shouldn't be returning these symptoms. Just simply because a parent asks. I don't care if you agree with me, disagree. I don't care. If a parent asks you, are these symptoms present? You should say yes or no. But they refuse, and that's phenomenal. um, it just kills me what's happening over here. So because of that, because the mental health people are refusing to tell parents the symptoms, Dorsey Pruder, who's a businesswoman and family coach, she jumps into the gap and it has, when this generates a lot of these family conflict cases generate a lot of documentation. So she gets all the documentation, emails, texts, reports, anything that's like documented in that's solid information coming in. And she hires a set of data coders, data taggers to read everything and categorize it into various categories. The three diagnostic indicators and 12 associated clinical signs are the categories she puts it into. And then develops that symptom information that can then be used to make the diagnosis, although it's a research methodology, not a diagnostic thing. So she can get so close, but the mental health person still needs to be there to make the diagnosis. But she can say, look, there's only one explanation from this. It's the type of research methodology is called a content analysis, and the specific methodology used is called data coding or data tagging. And so she's got a whole research project in the family courts based on the incompetence of the mental health people, just malpractice of the mental health people. Um, but but she's got massive amounts of wonderful data, archival data, which is like one of the best. It's already collected. And so Melanie Greenham got a memorandum of understanding, ran it through her institutional review board, and um, we looked at the presence of the 12 associated clinical signs in 46 families. All 46 families had the three diagnostic indicators. Now, none of the 46 families should have any of the three because they are impossible symptoms. All 46 families in the family court had the three diagnostic indicators. Guess what? All 46 of these families have the pathology I described in Foundations. There's your prediction, and there's your accomplishment of it. So the model that predicted that you'd find these symptoms is an accurate model. Foundations is not a theory. Foundations is a diagnostic treatise. And so everything I'm telling you about the pathology is absolutely 100% true and accurate, as well as everything I tell you about the surrounding mental health people, about them being ignorant, incompetent, unethical, uh, malpractice, failing in their duty to protect, all these things. That's all accurate too. Um, so 46 families had the three diagnostic indicators, but that wasn't the focus of the that's amazing, but it wasn't the focus of the research. We looked at the 12 associate clinical signs. So we're looking that's a prediction. I'm like predicting that I'm going to hit the home run in the left field bleachers, but not just in the left field bleachers. I'm going to hit the home run in section 207, row 32, seat 5 in the cup holder. So these associate clinical signs are making, when I'm predicting words used, that's in the cup holder. And sure enough, they showed up. Here's from data, actual data in the family courts, not opinion pieces, not this is from the data of 46 families in the family courts that, and see how we can define who they are using the 3 diagnostic indicators. That's called an operational definition. So, with the 3 diagnostic indicators, um, one family had 5 ACS, 4 families had 8, 12 families had 9, 11 families had 10, 14 families had 11, 4 families had 12. So all 46 had 5 or more of the ACS, and 41 out of the 46 families had 9 or more associated clinical signs. That's phenomenal. Okay, foundations and an attachment-based model of the pathology is 100% true and accurate. You want research, there's your research. So we need to put the argument and the fighting around these kids to close, and we need to get back onto a treatment approach. Treatment depends on diagnosis. So right now, this is up on ResearchGate, so everybody can go read it and decide for yourself. Melanie's done a great job. She has 3 of these in a series about the dark personalities and delusional disorders in the absence of research in the family courts. But here's the prevalence for each one of those, just interestingly. So ACS1, the use of the word forced, 85% of the families of these 46 families had ACS1 use of the word forced. I look at that when I hear the use of the word forced, that's a trigger, boy. Boop. And you can listen for it from the mental health people or from the pathology itself, the child or the pathological parent. Use of the word forced. The child's being given an opportunity to have a loving, bonded relationship with both parents. That's the truth. The child's being given an opportunity to have a loving relationship. We're not forcing the child to be loved. That's insane. And then the issue is we want love getting from the parent to the child. Oh, we're forcing the child to be loved. Oh, heavens, no. I mean, that's like, and so when I hear the word forced, that's a trigger for me. That's why the star is there. Empowering the child to reject a parent 100% of the time. So if that's present, wow, it's always present. The child, we should allow the child to decide on visitation. When the child's not ready yet, as soon as the child gets ready, then we should empowering the child to reject a parent. The exclusion demand was at 63%, and parental replacement was 54%. Now, I read those because, in my view, if either one of those is present, the pathology is present, in my view. And now get the research and find out. But the problem is, you can see that each one of those, the prevalence is about 50% in the population. So it's not always present. But this is based on data, the data that's generated from reports and texts and emails. I bet these numbers may actually go up if we had clinical interviews, if we had the mental health people, the psychologists were actually conducting clinical interviews to collect this information. I think we find the prevalence of these would go up. Unforgivable event, 96%. So that again, what happens? There's some event in the past, the unforgivable grudge, and the child holds on to that because there's no actual thing that's causing the pathology. There's no actual stimulus that's causing the response. And so they have to maintain. And that's where the stupid, incompetent mental health people think it's a PTSD symptom because it's from the past. No, it's not. It doesn't even meet criterion A for PTSD. There's been no trauma. And so it can't be PTSD. There's no trauma from that unforgivable event. It was emotionally distressing. That's not trauma. Trauma, defined by the American Psychiatric Association, is exposure, actual or threatened exposure to death, serious injury, or sexual violence. If there's no exposure to one of those three, death, serious injury, sexual violence, there's no PTSD symptoms. You can have bad stuff happen. You can have, it's uncomfortable, it's stressful, lots of things, but it's not a trauma that will produce PTSD symptoms. Okay. And so that the unforgivable event 96% of the time, because it's a false pathology. They're having to generate the reason for it to be there. Liar, fake, again, 87%. And that goes with, the use of the word forced at about 85%. And then the deserves to be rejected at 96%. All three of those, if I hear liar or fake, the child says, oh, my parents such a fake, they're one way with everybody else, but they're different with me. So the liar or fake, um, I love you. Oh, yeah, no, you don't. You're being so fake. 87% in the data. That's interesting. And when I hear that, there's only one explanation again for the pathology. So I know when I hear these little things that I'm on the right track. You still collect the 12 the three diagnostic indicators. Do a mental status exam if you want. If you don't want to believe me, you can go collect the symptoms for yourself. It's a shared persecutory delusion, factitious disorder, factitious attachment pathology imposed on the child. The reasons for rejection, 100%. Yeah, it's going to fit into one of those reasons that I identify. Unwarranted use of the word abuse, 89% of the time. Yeah. So if you got one parent accusing the other of abuse, we need to get a proper risk assessment for child abuse, period. So we got, use of the word abuse. Let's get a proper risk. But it flows both ways. If it's not actual abuse, then it could be that borderline manipulative Machiavellian manipulation, unwarranted use of the word abuse, has to do with projection, a whole bunch of other stuff, manipulation, the virtuous victim presentation, bunch of stuff with that. Borderline. Number 9, excessive texting and phone call. This was only at a 30%. This is the lowest of the ACS, but I've seen it in families, and I'm sure a lot of you have, where the other parents intruding with text messages or emails into the targeted parent's time with the child. So I suspect this one would go up too if it was actually gathered by clinical interviews rather than looking at text messages and emails and reports and stuff to identify this symptom. Role reversal. It's not me, it's the child who is 40%, again, around 50%. The families show this one. Deserves to be rejected. That's the theme. That's the spousal abuse theme that we have. The targeted parent deserves to suffer, deserves to be rejected 96% of the time. That theme is there. And disregard of the court 100% of the time. So the little baseball's rolling around the cup holder and, seat 52. So 100%. Three of the associated clinical signs were present at 100%. Three were at 90%. Three were at 80%. Two were about 50%, and the lowest was that texting one at 30%. So this is data out of the family courts. Okay, this is not an opinion. This is data out of the family courts. So given this data that these symptoms are present, these symptoms should be collected all the time, routinely. I don't care whether you believe me or not. If you want to explain them some other way, that's fine. But you should at least be collecting the symptoms. Geez Louise. The other is the parenting practices rating scale. And the reason for this is we got a differential. Is the targeted parent abusing the child, or is the allied parent psychologically abusing? So this one speaks to that first differential. Is the targeted parent abusing the child? Well, let's document what their parenting is. And so it goes through 4 different levels. Level 1 is clearly abusive range parenting, and it's a rating by the mental health person. The mental health person conducts a risk assessment for child abuse, whatever the concerns are, talks to the allied parent, talks to the child, does applied behavioral analysis, gets out what the what the concerns are, and if there's child abuse concerns, and then to check it off, yes. And so then protect the child, physical, sexual neglect, psychological. Then level two is severely problematic. It might not quite make a diagnosis of child abuse, but holy cow, this is a very angry, hostile parent or very neglectful parent, uninvolved parent or something. So that's level two, severely problematic. Level one and level two parenting would be abusive range. So let's document that, please, so that when it comes for a second opinion, I can look at the child's symptoms, but I can also look and say, is this a normal range parent? If they're a level one or two parent based on mental health assessment, diagnose what the child abuse is, put it on a treatment plan, fix it. That becomes the focus of our treatment. I don't care about, cross generational coalitions and everything else, as long as I have a targeted parent who's abusive, a two-person attribution of causality. We put it on the treatment plan, we fix it, and then we restore a healthy detachment bond to that parent. But if that parent is not abusive, if they are a normal range parent, level three, which is kind of normal range, but there may be a little problematic, there may be little bumpy things here and there, but they're a normal range parent, that's level three, or a normal range and healthy parent, that's level four. If they're in level three or four, then they cannot be causing the severe attachment pathology displayed by the child. And so now we look to the other, and that's to diagnostic indicator one, which is attachment system suppression towards a normal range parent. How do we decide normal range parent? Parenting practices rating scale. It's not an assessment, it is a documentation of the assessment conducted by the mental health person. So the mental health person can do whatever they want to do. We just need them to answer these questions for us so we can verify their diagnosis or lead to a more accurate diagnosis. Tell us what the symptoms are, please. But they refuse. And last time I asked parents to do this a couple of years ago, the mental health people would retaliate against you for asking this. So they'd say no, and then they would write bad reports about you and do so. And so I had to stop asking parents to ask their mental health people for the symptom information because the mental health people would retaliate against the parent. You were causing a narcissistic injury to them by exposing their ignorance and incompetence. Holy Toledo, these are the worst mental health people ever. The mental health person should never be a danger to the patient. But they are over here, over in the family courts. The mental health people are dangerous to the patients. That's insane. But that's what we got in the family courts until somebody actually cares. Um, so, in all cases of severe attachment pathology surrounding child custody, the differential diagnosis is child abuse. It's going to be child abuse by one parent or the other. If you've got a child rejecting a parent, that's a child abuse one way or the other. Either the targeted parent is abusing the child in some way, thereby creating the child's attachment pathology towards that parent. That's a two-person attribution of causality. Or the allied parent is psychologically abusing the child by creating a shared persecutory delusion and factitious attachment pathology in the child for the secondary gain of manipulating the court's decision on child custody and to meet the parent's own emotional and psychological needs. Factitious disorder imposed on another, shared persecutory delusion, child psychological abuse. One way or the other, that's your differential. And so the lackadaisical absence of urgency, failure in their duty to protect the forensic psychologists, all of them for 40 years now, is malpractice range, in my view. And somebody's going to have to explain to me why all the forensic psychologists should not lose their license for negligent malpractice and failing to protect the child and failing to protect the targeted parent from spousal abuse using the child. Because as mental health people, we have two obligations on danger. So we have an obligation not only to protect the child from child abuse, which is what I keep hammering on, we have an additional obligation to protect spouses from spousal abuse. And you're a spouse, Everybody says, oh, you're justified rejection. No, it's spousal abuse using the child as a weapon, and we have an obligation to protect you from the spousal abuse. Oh my goodness, it's such a mess over here. So diagnosis guides treatment. We need to get back to healthcare. We need to get, if the forensic psychologist did a very bad thing, they became mini judges in the legal system. So they stopped being doctors. They came up with this new experimental approach to service delivery where they're no longer doctors diagnosing and treating pathology. They're now mini judges deciding on custody and stuff. That was a bad thing to do. Psychologists need to get out of the legal system and get back over to being doctors in the healthcare system. We need to diagnose and treat pathology and tell the court accurately what the diagnosis is so that the court can make its decisions regarding custody. And we need to tell the court what the treatment plan is so we can fix the pathology and get it out of the courts and fix the problems that the court is facing regarding child custody. So we need to get back to diagnosis and treatment. So you, the parents out there, do you want a treatment plan to fix the attachment pathology displayed by the child? No, don't worry about parental. Stop using parental alienation. This is an attachment pathology. You want a treatment plan to fix the attachment pathology. It's now up to the mental health people to give you that. The doctors. That's their marching orders. Give you a treatment plan to fix the pathology. Treatment depends on diagnosis. The treatment for cancer is different than the treatment for diabetes. The treatment for child abuse by the targeted parent is different than treatment for child abuse by the allied parent. And that's critical because we got child abuse by one parent or the other. The treatment is protectively separating the child from the abusive parent. Which parent is abusive? We need an answer to that question. If you don't protect the child when there's severe attachment pathology, I know the child is being abused. I don't know which parent's doing it, but if you're not protecting the child from one or the other, and there's severe attachment pathology, I know the child is being abused and you're failing in your duty to protect. When the child abuse is a considered diagnosis, our diagnosis needs to be accurate 100% of the time because misdiagnosing child abuse is too devastating for the child. And so we need to do whatever we need to do as doctors to make sure the diagnosis that we return for our treatment plan and for the court's information is accurate 100% of the time. And there's ways to do that. Applied behavioral analysis, second opinion consultation, diagnostic checklist, document it up. Give the court the diagnostic checklist and the parenting practices rating scale. Give the court the information that you are using for your diagnosis. I'm seeing these attachment suppression towards a normal range parent. I'm seeing narcissistic or phobic anxiety displayed by the child, and I'm seeing a persecutory delusion in the child. You meet with the allied parent, you confirm the persecutory delusion in the allied parent. Now you have a shared induced persecutory delusion, child psychological abuse. So give the court that information. Diagnostic checklist and parenting practices rating scale. I think the court should be getting that on a routine basis. And you can come up with other opinions and you can come up with anything else you want. Just give them the diagnostic checklist. Give the parents, give the courts, give everybody a standardized report on what the symptoms are based on the advice of Dr. Childress, a clinical psychologist in the family courts, and foundations and the application of Bowlby, Minuchin, Beck, and the applied knowledge. There's zero reason this should not be routinely done. And the patient, you parents, should never have to explain the pathology to the doctor. Imagine going in, to your physician with like possible cancer, and you have to explain what cancer is to the doctor and how to assess and diagnose for the cancer, more or less how to treat. And you're having to explain to the doctor what the pathology and its diagnosis is. That is insane. That indicates to you how low the professional practices are in the family courts from these psychologists. If you're having to explain what the pathology is to a doctor, they are just the worst, absolutely the worst. You might as well go to, your local shopkeeper or plumber or somebody. You can explain the pathology to them. The failure of professional psychology in the family courts. So, you parents, I've said this before and want to reemphasize it. You targeted parents. It's not your fault. You did nothing wrong. Okay. There are bad people doing bad things, and it's not your fault. We're going to make them stop. But you've been put in a position where you have to prove reality and prove you're not abusive and prove no, no, no. That's not your job. It's the job of the doctors to come in and protect you, accurately identify the problem, accurately diagnose the pathology, and come up with an effective treatment plan to fix it. And because it's child abuse, it's up to the doctors to identify which parent's abusing the child, and to protect the child and get the child on an effective treatment plan that fixes the problem. That's our job. Now, the Gardnerian PAS experts are immensely ignorant, and I will just offer up that they are so ignorant that they have to make up new pathologies because they don't have the knowledge to apply, and so they don't know attachment, they don't know family systems, they don't know delusional thought disorders, they don't know factitious disorders or complex trauma, and so they can't apply the actual knowledge. The only thing they can do is make up and say, oh, I have a new pathology here. No, you don't. You're just ignorant, massively ignorant, and a very poor diagnostician. So, but they want to be experts. They want to be experts so badly, but they're not actually experts in anything because they never put in the effort to become an expert in real things. But they want to be an expert. So, wow, if I just make stuff up, then I can just be an expert and everybody can be, you're an expert and I'm an expert and everybody's an expert because, well, we're making stuff up. So that's your Gardner and PAS people. On the flip side of that, the forensic psychologists are immensely ignorant. And but they want to be experts in something. So they make up this new experiment in service delivery. They called it forensic psychology, where they stop being doctors and become mini judges, and they do this behemoth 6 to 9 month 50-page evaluation that doesn't even diagnose what the pathology is, so that even after their big 6 to 9 month tens of thousands of dollar custody report, we still need another assessment to diagnose which parent is abusing the child so we can develop a treatment plan to fix it. Let's just go straight to clinical psychology. Let's get a treatment plan. But the problem is the clinical psychologists have abandoned you for 40 years. So they're not competent working in the family courts anymore either because they've just left you. And it's because it's too dangerous. I think, a passive aggressive kind of thing. If you're going to threaten their license, they're not going to come here. They'll give you your own special psychologist and then just abandon you to them to do whatever they want and provide no oversight to them. Where are the licensing boards? Why am I out here, the one that's raising issues about 2.01 competence, 2.04 bases for judgments, 9.01 bases for assessment, duty to protect obligations? Why am I the one, Dr. Childress, out here holding my professional colleagues accountable under 1.04 and 1.05, my obligations under this APA Ethics Code? Where are the licensing boards? Why aren't they holding? They do it in ADHD. They do it with autism. They do it with eating disorders. They do it with some. They hold accountable for competence in every other domain of professional psychology, except in the family courts. In the family courts, they've allowed things to go absolutely to the bottom, where you have people just self-asserting to be experts when they have zero, zero knowledge of what the pathology is. The idea that professional psychology allowed an experiment on families, an experiment in service delivery to a vulnerable population. These parents were vulnerable. They're getting hit with a factitious disorder. The reality's up in the air. And they're in the new system, a legal system that's adversarial, that's harsh. And they need a diagnosis of what the problem is and a treatment plan to fix the child. And they got courts that are interfering with their ability to make decisions and their autonomy, and can take the child and put them unsupervised. That to conduct an experiment on this vulnerable population without proper safeguards was an abomination. To just give these people carte blanche to come up with whatever experimental approach they wanted was immensely negligent on the part of professional psychology. We just didn't care. And as a result, we've lost thousands and thousands of children and thousands of parents that had their lives destroyed. We lost to spousal abuse and child abuse for decades because of this failed experiment. And it's a failed experiment. And we need to acknowledge it's a failed experiment so that we can actually move on to the solution. But the moment we do, all the forensic psychologists become problematic. And so they don't want to have their ignorance, incompetence, and malpractice exposed. The Gardnerians want to keep parental alienation. They don't want their ignorance exposed because then everybody stops being an expert and you need to go work somewhere else. You need to actually get a job working in substance abuse or autism or ADHD because you're not working in the family courts anymore. Not if you're a forensic psychologist for 20, 30 years and you've been participating in the abuse of children. You're going to be, your credibility and your professional standing is done in the family courts. If you're a forensic psychologist or if you're a Gardner PAS person, you're not relevant and you need to go work somewhere else. You need to work not with children, hopefully. Go work with adults somehow. If you're going to be lazy, ignorant, incompetent, unethical, and fail in your duty to protect, don't work with children. And don't work with children and child abuse. So that's your situation. You've got experts everywhere you look, but nobody who's actually competent. And it comes from the legal system calling these psychology people expert testimony, and it kind of goes to their head and it kind of fills up their narcissism. That's how it captivated everybody. It captivated Gardner that way with his narcissism. He didn't put in the effort. He didn't contain himself within the proper approach, which is you don't start making up new pathology. And that's going to force you to learn the established knowledge and apply the established knowledge. And so he escaped the rigors of professional practice by giving himself permission to just make up something new. And I can just do that because I'm special. And the rest of psychology said, no, where's your research? No, there's no such thing. And these are awful symptoms. No, 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 you're not allowed to do that. And then we fought for 30, 40 years about whether we're allowed to make things up or whether we have to apply knowledge. But the forensic psychologists did the same thing. They still used parental alienation in their reports. Now they're coming up with this new thing, resist refuse dynamic, totally made up. Daubert, Kelly Fryatt, it's totally made up again. But they're experts in resist refuse. It's a shared persecutory delusion and child abuse. It's not resist, it's child abuse. And if you're not diagnosing the child abuse, you're failing in your duty to protect obligations. So let's get a second opinion on your custody evaluation. Let's see what the actual pathology is. We can do it by answering the Diagnostic Checklist Parenting Practices Rating Scale. I can tell you what the diagnosis is if you give me that. Dorsey can do it. If you refuse to do it, she can go through all the data around there and identify this to check up on your diagnosis. But the mental health people just need to start collecting the symptoms. We need to stop fighting about this. We need to stop fighting about me. Okay. I'm applying knowledge. If you disagree with me, bring the disagreement, make it specific, and let's have a professional level discussion about it. I'm willing to debate this with any Gardner PAS person. Bill Burnett, you and I, let's do an online moderated debate. Let's everybody hear, is there such a thing as parental alienation? We'll just go back and forth and you present your side, I'll present my side. Let's get it out there. Let's stop the arguing. Forensic psychologists, pick top forensic psychologists. I'll debate online moderated debate. Let's everybody hear the role of forensic and clinical psychology in the family courts. If you do a YouTube search, you'll find all sorts of stuff in quantum physics and in every other field, of science. You will find online discussion groups, online professional discussions from high-level organizations within the scientific field. We have the internet. Let's put up a moderated online debate. Gardner PAS people, Dr. Childress, forensic psychologist, Dr. Childress. I'll debate anything. Get your topic, put it up there. We need to end the fighting of the mental health people around this pathology so that we can get a clear movement forward. What's the diagnosis? What's the treatment plan? And let's fix the pathology in the family courts. Um, and so if you disagree with Dr. Childress, bring it and bring it specifically. Google ignorant, lack of knowledge or information. They are ignorant by definition of the English language. This is not some sort of insult to them that I'm coming up with. This is a definition of the English language that applies to them. They lack knowledge or information in delusional thought disorders, in complex trauma, in child abuse, in personality disorders, in attachment pathology, in delusional thought disorders, in factitious disorder. Because you know how I know? Are they applying any of it? Because they have an obligation to apply the established knowledge first before they make up new stuff. So are they applying it? Where? Show me their application of the established knowledge. Because if they're not applying it, I'm going to say they don't know it. And if you know it, then apply it, and then let's elevate the discussion within the professional psychology over here. And so they're ignorant by definition of the English language, and they continually prove their ignorance by using resist refuse dynamic, by using parental alienation, and by not using a shared persecutory delusion, by not using child psychological abuse, by not using factitious disorder or cross-generational coalitions or emotional cutoff, by not using the established knowledge, narcissistic, borderline, dark personalities, then they are demonstrating that they are ignorant, and ignorant opinions have no value. Google indolent, wanting to avoid activity or exertion, lazy. And that's the Gardner PAS people want to be experts, but they are simply lazy. They don't want to expend the effort to the exertion necessary to actually learn knowledge. But they want to be experts so bad, so they just give themselves permission to make stuff up. They're just lazy. The forensic psychologists are not wanting to avoid the exertion necessary to learn attachment, to learn diagnosis, to learn delusional thought disorders and personality disorder pathology. They don't want to expend that effort. They just want to do their custody evaluations and have an opinion about which parent should have a child, and based on nothing, because they're lazy. They're lazy. This is a pathology of motivation. And the level of professional services in the family courts is abysmal. It is absolutely at the bottom. Where are the licensing boards enforcing competence? The courts are making a monumental decision surrounding this child. This child's life is going to change drastically based on the court's decision as to how it handles this high conflict litigation around the custody. The court deserves the best possible information out of mental health. And instead, it's getting the worst. It's just getting opinions based on nothing. That needs to change. Professional psychology has an obligation to the court to give the court the best, and that's out of clinical psychology. Stop being custody evaluators. Let's give them a diagnosis. Let's give the courts an accurate diagnosis that the courts can rely on. Let's get a second opinion on it, get a third opinion on it if we need to. But let's make sure it's accurate, make sure the court can rely on that, and make sure we get these children and their parents protected from abusive range pathology in a narcissistic, borderline, dark personality parent. And so with that, I'm going to wrap up my coffee talk today on the diagnostic protocol. All this stuff, all these forms that I was talking about, it's up on my consulting website. I have 3 areas. The attorney area has handouts. The mental health consultation page has information for mental health people, and the parenting page has information that may be helpful to the parents on things. I meet with parents the first week of, not parents, I meet with the general public the first week of every month. I limit that to one time unless you're in California, but I'll talk to anybody just one time to find out what you want to talk about. If you look at stuff and you know your attorney wants to get me involved, then you can just, it's the scheduling's on my consulting website. If you will just want to kind of organize about the pathology and talk about what the pathology is generally and what I recommend to do, we can do that. If you want to talk about ADHD, autism, things, I'm a full service psychologist. You want to talk about sports or the weather, I'll talk to you once, except people in Oregon. No attorneys or no mental health people or parents in Oregon. So, with that, good luck to everybody, and we'll talk to you next Sunday. Take care. Bye bye.